Can everyone hear me and see my screen?
Yes, perfect. Thank you.
Great. So unsurprisingly, I have no financial disclosures. Today, I will be talking about perioperative opioid prescribing in otolaryngology. And I'm Steve Hasday. I'm one of the third-year residents. So a quick outline for today. First, we'll talk about some national trends and go over some background information. Then we'll look at some specific data surrounding opioid prescribing in otolaryngology. And then finally, we'll kind of have a conclusion section, which is basically recommendations for pain management for a variety of otolaryngology procedures for some national trends. So let's just talk some basic numbers. In 2017, there were more than 70,000 drug overdose deaths in the United States. More than 2/3 of those were opioid related, almost 50,000. From 1999 to 2017, there were more than 700,000 total drug overdose deaths in the United States. Over that period, the rate of drug overdose deaths increased substantially. In 2017, the age-adjusted rate of drug overdose death was 21.7 per 100,000 of population, which was 3.6 times higher than the rate in 1999, which was 6.1 for that same 100,000 of population. Of those 700,000 total deaths, nearly 400,000, greater than 50% of the drug overdose deaths in the US involved opioids. Over that same period, the proportion of drug overdose deaths significantly increased, more than 200%. As we saw a couple slides ago, the percentage of total drug overdose deaths now involving opioids is more than 2/3. For the whole period, it was over 50%. Now it's more than 2/3. When reviewing the types of opioids resulting in overdose death, there appear to be 3 distinct waves or periods that you can find over this period. First, an initial rise in prescription opioid overdose death starting in 1999, then more or less leveling out at about 2010. This ushered in a second rise in heroin overdose deaths, which took off in the first half of the 2010s. And in the most recent years available seem to be starting to level off. But they've been replaced largely by a third explosive wave that came with the introduction of cheap and illicitly manufactured synthetic opioids like fentanyl and its analogs, which have mostly come from China and started in about 2012, 2013. The rise of prescription opioid-related overdose deaths understandably became a significant focus of the healthcare system starting in the early 2000s. They found it to be both related to medical use, meaning prescribed pills that were used by the patient for their intended purposes, but resulted in overdose death, and non-medical use, which covers use of prescribed pills that are either diverted from the intended recipient or misused by the intended recipient to get a feeling that they cause rather than pain abatement. First, we'll take just a very brief look at overdose deaths associated with intended medical use. This is a 2011 JAMA study that looked at a cross-section of Veterans Health Administration patients from 2004 to 2008 and aimed to assess the risk of opioid overdose related death with various opioid prescribing patterns. They looked at number of pills being prescribed, the types of refill being offered, maximum daily prescribed dose, and a number of other factors. They used an as prescribed approach in their analysis, so they didn't actually determine how many pills were being taken, but they assumed that patients took all prescribed opioids at the prescribed dose and on the schedule recommended by their clinicians. They found that among patients with acute pain, which included post-operative surgical patients, being prescribed 50 milligrams or more oral morphine equivalents on a daily basis was associated with significantly increased risk of opioid overdose-related death. And then just a brief term, I'm going to be using the term morphine equivalents or morphine milliequivalents frequently through this talk. It's a standard way to assess the amount of opioid given, no matter which specific opioid medication is used, based on its conversion factor to morphine. So oxycodone has a conversion factor of 1.5. So 10 milligrams of oxycodone is 15 morphine equivalents, whereas tramadol has a conversion factor of 0.1. So 50 milligrams of tramadol is 5 morphine equivalents. The hazard ratio for patients receiving a maximum daily dose of 50 to 100 morphine milliequivalents was 4.73, and for those receiving more than 100 milliequivalents daily, it was 6.64. So quite an increased hazard ratio with those higher levels of prescribing. Well, what about non-medical use? And again, these are prescribed opioids that are either diverted from their intended recipient or misused by the person who was supposed to receive them. In 2014, 10.3 million people, which is about 3.2% of the US population, reported using prescription opioids non-medically. And by 2018, the number had grown to 11.5, which was greater than 3.5% of the US population in that year. This figure is from a 2017 National Survey on Drug Use and Health report on how people obtain the prescription opioids that they end up misusing. The majority, 66% almost, receive diverted pills from friends or family. The sections we're looking at here are the beige section that takes up about half the pie, which is getting them for free. The light blue section, which is buying them from friends or family. And then the gray section, the black section, which is stealing them from friends or family. A further 22% are misusing opioids that are prescribed to them by a single doctor or their doctor. So all of that leaves just a little bit over 10% are either buying prescription pills on the street, doctor shopping and obtaining multiple prescriptions, or obtaining pills from other sources. The pills are coming from people who are getting them, typically prescribed for a reasonable reason by one doctor. So if so much diversion and misuse occur, that kind of begs the question, how much prescribed opioid is actually being used versus how much is available for diversion? And moreover, just for this talk, we'll focus primarily on how much peri-operative opioid is being used or is available for misuse. So this study from the University of Michigan showed that post-operative opioids go unused by patients at an alarmingly high rate. They said almost 80%. And this overprescribing results in a huge opportunity for diversion and misuse. So given all of this information, there have been significant efforts over the past decade plus to reduce opioid prescribing in order to reduce misuse and overdose death. This is from a 2016 New England Journal article, which shows that these efforts have focused mainly on educating health professionals about opioid prescribing, as well as the public about appropriate use, and implementing prescription drug monitoring programs, among another of several other interventions. And let's see how these interventions have actually had an impact on opioid prescribing patterns. This graphic represents by state the rate per 100 persons of opioid prescriptions. The burgundy color indicates states where there's more than 1.07 opioid prescriptions per person. So more than one opioid prescription per person in that given calendar year. The dark red indicates 0.83 to 1.07, so almost one prescription per person. This is what the rates of prescribing were in 2017. You can see kind of a hotspot in the Southeast. By 2012, there had been a significant increase in opioid prescriptions per 100 population. Still, the Southeast was kind of the main driver. But then by 2017, we showed that there had been significant reduction in opioid prescribing when compared to those previous years. And then this is just a by-year national trend, which shows that from 2006 to 2010, there was increasing rates of prescribing per 100 population, then a stabilization period from 2010 to 2012, followed by a significant decline until the end of the study period in 2017. By 2017, there was almost a 30% reduction compared to the maximum rate of opioid prescribing half a decade prior. So this is a study that looked at variations in opioid prescribing rates across a variety of specialties. They used the National Prescription Audit, which is something, a database maintained by IMS Health, which apparently no longer exists or was folded into another company. But it's a database that is used to determine the annual counts of all pharmaceutical prescriptions dispensed in the United States. And this covered the period of 2007 to 2012. They found that in 2012, surgical specialties were writing only 1.8% of total prescriptions in the United States, but were writing nearly 10% of all of the opioid prescriptions. At 36.5% of their total prescriptions written, surgeons wrote for the second highest proportion of opioids. Only pain medicine specialists, who are writing nearly 50% for opioids, had a higher proportion of their overall prescribing as opioids. Overall, as shown in that earlier US map representation of opioid prescribing rates, during this study period, again 2007 to 2012, prescribing rates actually increased by 5 to 7%. However, this data set allowed the authors to actually assess for annual changes over that time for a variety of medical specialties rather than just on aggregate. And they found that that overall increase of 5 to 7% was largely driven by a few specialties, specifically PM&R, pain medicine, internal medicine, and then various primary care practitioners. But surgery, dentistry, and emergency medicine, although they still accounted for a pretty significant number of opioid prescriptions, approximately 20% over that study period, they decreased the proportion of total prescriptions that were for opioids. So this group was a little ahead of the curve in reducing their opioid prescribing. They lowered their proportion of prescriptions for opioids even as the national numbers grew. And that kind of heralded the change that we saw from 2012 to 2017, where those numbers overall finally started to come down. So returning to that 2016 New England Journal study that I just brought up very quickly earlier, the researchers were actually assessing the relationship between the use of prescription opioids and heroin use, which saw that increased proportional increase in opioid-related death related to heroin use, starting with that second wave in 2010. I found these quotes really interesting. I thought I'd just give you a second to read them. And basically, the conclusions of these authors were, while the efforts to reduce opioid prescribing overall have been largely successful, there remains a question of whether these changes in policies and practices have actually led people to heroin use and increased heroin-related overdose deaths over that period. This is from that article. It's another representation of that kind of three-wave graphic that we saw before, just zeroing in on those prescription opioids and that heroin. As we've previously seen, the rate of increase of overdose death per 100,000 of population due to prescription opioids slowed, just as the rate of increase due to heroin overdose rapidly grew, starting in that 2010 period. So do heroin users start by misusing prescription opioids? This is a large national sample of heroin-dependent respondents, long-term heroin users, dating back to the 1960s for when they actually started their abuse. And they found that since the 1990s, more than half of all long-term heroin-dependent respondents or heroin-dependent people indicated that they first started abusing prescription opioids and later started abusing heroin. That percentage reached a maximum of more than 70% in the 2000s, and now it's a little bit more than the 60s, the 60% for the most recent decade that we have information. So yes, I think we can say that heroin users often do start by misusing prescription opioids. So that kind of leads us here. So we've seen that surgeons prescribe a significant proportion of the opioid prescriptions, that a significant number of those pills are diverted or misused, with more than 11 million people misusing them in 2018 alone, and that a significant proportion of long-term heroin users actually started using prescription opioids first. whether they progressed to using heroin or not, everyone with an opioid use disorder had to start somewhere. But the question is does perioperative opioid prescribing result in long-term opioid use? This was a CDC study that used a different IMS Health data set. This one was called LifeLink Plus, which is a representative data set of prescribing for the US commercially insured population. They found that the risk of persistent opioid use 1 year after the first initial prescription was a minimum of 6% and increased approximately 1% daily starting on the 4th day of the supplied prescription opioid. So about 1 in 10 people given a 1-week first course of opioid pain medication were still using opioids 1 year later, and about 0.7 in 10 were still using opioids 3 years later. And just remember that 1-week first course because I'm gonna bring it up in a little bit. This is a 2012 retrospective cohort study of elderly patients using population-based administrative Ontario, Canada, covering the 1997 to 2008 period that looked at long-term opioid use following peri-op prescriptions of opioid pain medications for low-risk procedures, including cataract surgery, lap choles, and TURPs. Only 7% or so were actually issued prescription for post-op opioids. But of the patients who did get a post-operative prescription, which included actually more than 25,000 total patients, slightly more than 10% became long-term opioid users 1 year out from their procedure. Of interest, codeine was the most prescribed initial opioid, initially in the form of, typically in the form of Tylenol 3, but at the 1 year mark, a significant number had transitioned to more potent opioid medications and more potent formulations. And then this is another retrospective cohort study that used nationwide insurance claim data in the United States covering the years 2013 and 14 to identify adults who had undergone surgery and received perioperative opioids without any prior opioid use in the prior year, basically opioid naive patients, to assess for persistent opioid use at 90 days post-op. Of note for us, the minor surgical procedures that they looked at included thyroidectomy and parathyroidectomy, and across both groups, they found that approximately 6% of people were persistent opioid users at 3 months post-op. In the study, they also aimed to determine if there are any preoperative patient factors that increase the risk of long-term opioid use following surgery. They found increased persistent opioid use among patients with pre-existing mood or anxiety disorder, psychosis, tobacco use, alcohol or substance abuse disorders, and chronic pain conditions. This is a paper from JAMA Plastic Surgery that also assessed for patient factors contributing to persistent and prolonged opioid use following surgery. Persistent was categorized in the study as 3 to 6 months after surgery, and prolonged was 6 to 12 months after surgery. It's a retrospective study of a national database of private insurance claims covering 2007 to 2015, and they looked at 5 common plastic surgery procedures, including rhinoplasty and blepharoplasty. More than 90% of patients received opioid prescriptions post-operatively in this study. And then among the patient population that received opioids, so not including the 10% that didn't, persistent opioid use was found in 10% of patients, and prolonged opioid use, so 6 to 12 months out from surgery, was found to be occurring in 3.5% of patients. So a little bit lower than what we've seen in other studies, but somewhat on track. Again, they looked at patient factors, and they found that female gender, depression, anxiety, chronic pain, tobacco use, and substance abuse within the year prior were all associated with an increased risk of persistent and prolonged use of postoperative opioids. So now that we've kind of had a general picture of the problem and understand some of the factors contributing to long-term opioid use in postoperative patients, let's discuss some of the studies about opioid prescribing in otolaryngology. This paper was just based on 2015 Medicare Part D claims data and was just aiming to characterize the opioid prescribing rates across multiple surgical specialties. I'll zoom in, and you can see otolaryngology. It showed that just under 10% of all prescriptions written by otolaryngologists are for opioids. This paper used that same Medicare Part D data from 2015. They found that just over 9,000 practicing otolaryngologists wrote nearly 135,000 prescriptions for opioid medications, and that these prescriptions covered a supply of just under 1 million total days. And that came out to 6.9 days per opioid prescription. I asked you to kind of keep that 1 week time period in the back of your mind, because we've seen that there's an increasing risk of long-term opioid use based on the length of an initial opioid course. So the question is nearly 7 days, 6.9 days, is that appropriate? Again, 1 in 10 people given that course will still be using opioids 1 year later, and 0.7 in 10 will be using opioids 3 years later. This is data from an online survey conducted by the Academy. There were a total of 596 respondents, which represented just a 7.4% response rate, but the findings are still pretty interesting. The survey asked basic demographic questions as well as general questions regarding prescribing patterns, but then they asked respondents to input the typical quantity of whatever their preferred opioid tablet that they prescribed for each of 12 common procedures. You can see those are tympanoplasty, mastoidectomy, thyroidectomy, pediatric and adult tonsillectomy, ESS, septoplasty, rhinoplasty, just a soft tissue excision, neck dissection, cancer resection, and DL. And then we can see across these procedures that there's really great variation in the quantity of opioid tablets being prescribed by otolaryngologists. Overall, they prescribed the most for adult tonsillectomy and the fewest for DL. But I'd like to take a second to just look at a few specific procedures. We're going to look at data for just a handful of procedures here, but every time I mention a procedure that you commonly perform, just take a moment and think about how many Norcos or Tramadols you might have sent your most recent case home with. These are the results of an electronic survey distributed to the membership of the American Head and Neck Society's endocrine section. They had a 34% response rate from a total of 102 surgeons. In all, they found that almost 2/3, 65.7% of surgeons prescribe opioids following thyroidectomy and parathyroidectomy, but they also found a really wide variation in total morphine equivalents being prescribed. Most surgeons fell somewhere between 50 and 225 morphine equivalents. There are some additional studies that I'm going to mention as well. The first was a prospective study of 2 large academic institutions that found that despite being prescribed up to 120 morphine equivalents, the pain requirements of 93% of postoperative thyroidectomy and parathyroidectomy patients were adequately addressed with fewer than 20 morphine equivalents. Another single institution study revealed that post-thyroidectomy patients were routinely prescribed enough opioids to satisfy regular use for a 14-day duration, despite a mean discharge pain score of 3 on a standard 0 to 10 scale. At that level of pain, 3 out of 10, which is considered mild, if they were on a PRN pain regimen in the hospital, that would typically be treated without any opioid medications. So just something of note. Hopkins convened a multidisciplinary panel to make opioid prescribing recommendations for 20 common surgical procedures across multiple surgical specialties. They included recommendations for just 2 ENT procedures. One of those was thyroidectomy, partial or total, for which they said you should prescribe no more than 15 tabs, totaling no more than 75 morphine equivalents. Their other procedure that they touched on was cochlear implant, for which they recommended against prescribing any opioids postoperatively. And we'll talk about a little bit more about recommendations like these, similar recommendations a little bit later on. What about ESS? This study presented the results of an electronic survey sent to more than 1,700 members of ARS to better characterize prescribing patterns for pain management after endoscopic sinus surgery. It was completed by 168 members, so for a response rate of just under 10%. What they found was that nearly 95%, 94% basically, prescribed some form of opioid medication following ESS, and the average number of prescribed pills was nearly 30 or almost 150 morphine equivalents. So is this appropriate? This is a prospective study from Cornell that included 42 patients between November 2017 and June 2018 undergoing outpatient elective rhinologic procedures. They included septoplasty with TURB reduction, ESS with and without septoplasty. What they found was that pain peaked across all procedures on postoperative day 1 and 2, and by post-op day 3, need for opioid medication had fallen to 0. For all the procedures assessed, they looked at the mean cumulative morphine equivalents used, and it was 11.2. That's not pills taken, that's cumulative morphine equivalents. The study assessed pain on a 100 millimeter visual analog pain scale, and they found that for patients who underwent ESS with septoplasty or septoplasty with turbinate reduction, pain peaked at approximately 30 out of 100 on post-op day 1, and pain was below 10 out of 100 by post-op day 3. Again, on our inpatient scale to 10, a 3 out of 10 is considered mild pain and is not treated with opioid medications typically. On average, those same patients required the most morphine milliequivalents post-op day 0 and 1 as well, and opioid use fell to 0 again by post-operative day 3. A retrospective chart review performed at Mass Eye and Ear was consistent with these results of this ARS study. It showed that nearly all patients received an opioid prescription. Again, the prior study was 94.05. This one is 94.8% following ESS. These patients received an average of 15.6 tablets, a little bit lower than the 27 we saw before. More than 90% of those who received an opioid prescription filled that prescription. However, at clinic follow-up, nearly 3/4 of patients reported taking 0 opioids postoperatively, and fewer than 5% of patients actually required a refill of the opioid pain medication. The predictors of actual opioid use in this postoperative population were concurrent turbinate reduction and concurrent septoplasty with ESS. Let's briefly look at 2 studies centered on interventions regarding opioid prescribing in children following TNA. They both resulted in significant decrease in opioid prescribing without significant changes in post-op ED visits or complications. The first is a Kaiser Permanente Northwest study. Following the addition of an age-based electronic health record narcotic protocol requiring physician override in order to prescribe any opioid to a patient below 7 years old, there was a significant decrease in perioperative opioid prescribing without any change in ED or urgent care visits or post-op complications. Prior to the order set implementation, more than 80% of pediatric patients were getting some type of opioid following tonsillectomy. And just by putting in this order set that required a physician override, that number fell all the way to 15.4%. And you can see that visit, phone call, surgery thing on the side there. That's when they were actually prescribed the opioids. So only 5% actually got it right after surgery. A number of the other ones came in the post-operative period, just due to some decreased pain control or poor pain control, where they thought an opioid might help. But that's a substantial reduction and quite a few pills that would not have been needed at all. This next study is from the University of Pittsburgh. It followed a new 2016 Pennsylvania state law requiring parental consent for opioid prescribing for pediatric patients, and limited the course to a maximum of 7 days. The post-consent period saw a statistically significant reduction in total opioid prescribed and the length of the prescription without significantly affecting post-operative outcomes. In fact, the only 2 statistically significant changes post-operatively were a lower concern for bleeding and reduced hospital readmission in the post-intervention group. Now we'll look at rhinoplasty. This study presented a case series of 62 rhinoplasty patients by 3 facial plastic surgeons who prescribed standard postoperative opioid-based pain regimens for all of their patients. They found that 15% of their post-rhinoplasty patients used no opioids at all, and that the patients who did use them, they used less than 10 total pills. And then while it doesn't quite match the 80% number for an unused rate that we saw earlier, they found that only about a third of the prescribed pills were actually being used by their patients. They noted no significant difference in opioid requirement with concurrent septoplasty, turbinate reduction, or if they had to do osteotomies during the surgery. Here's another 44-patient prospective study done at Cornell. These were patients undergoing rhinoplasty with or without septoplasty, and septoplasty with or without TURB reduction. They found that pain was less than 30 out of 100 on post-op day 1 for the septoplasty patients, and on post-op day 2, it was less than 30 out of 100 for the rhinoplasty patients. They found that a total of 10 tabs provides appropriate pain control for more than 90% of patients undergoing both procedures. So we've seen data about a number of post-operative pain and opioid requirements for quite a few common procedures. But I wanted to discuss some kind of general recommendations or more of a holistic approach to post-operative pain management following common procedures in ENT. These general recommendations are partially based on some upcoming Academy clinical practice guidelines for opioid prescribing, which are supposed to be released next year. They're still in the draft stage, so they can't be distributed or formally shared, but there are definitely some general recommendations that can be made from review of this upcoming guideline, and also quite a few of the works that I've been referencing throughout this presentation. So our first general recommendation is, prior to surgery, clinicians should advise patients and caregivers about the expected duration and severity of postoperative pain. In addition, prior to surgery, clinicians should assess for patient-specific factors that may alter the severity and/or duration of postoperative pain. Some of these factors include pain management problems following previous surgeries, increased psychological stress over normal surrounding this surgery, and also current marijuana use. Prior to surgery, clinicians should identify risk factors for opioid use disorder if planning to prescribe opioids for post-operative pain management. As we saw previously, some of the risk factors for prolonged use included female gender, depression, anxiety, substance use disorders of alcohol or drugs. This also extends to family history of those, tobacco use, chronic pain conditions. And then there are a number of validated screening tools that you can use for predicting opioid use disorder in your patients. The majority come from the chronic pain literature, including something called the STOPE, the revised opioid risk tool, the current opioid misuse measure. There's actually one that's been designed for use in surgical patients. This is called the Stopping Opioids After Surgery Risk Assessment Instrument. It's been validated for assessing the likelihood of sustained opioid use after a variety of general, cardiovascular, and orthopedic procedures based on specific patient factors. It looks at 9 patient characteristics, each with an associated risk score. They are age, sex, discharge location, so home versus non-home, socioeconomic status, procedure category of whether it's a minor or major procedure, length of stay in the hospital associated with the surgery, concomitant depression, anxiety, and then prior opioid use, either exposure or prolonged use. And you get a raw score out of 100. Based on that raw score, you're stratified into one of 3 risk categories. Those low-risk patients have approximately a 4% likelihood of sustained opioid use after surgery, versus the higher-risk patients, the high-risk patients, have more than a 35% likelihood of sustained opioid use after surgery. So knowing where your patient might fall in this risk stratification might alter or might affect your thoughts on prescribing opioids postoperatively. Our next recommendation is that clinicians should promote shared decision-making by informing patients of the benefits and risks of various postoperative analgesia interventions. Clinicians should develop a multimodal treatment plan for postoperative pain. Clinicians should advocate for non-opioid pain medications as first-line analgesics after otolaryngology surgeries. We'll kind of take these 2 recommendations together. I think most of us are used to using a variety of non-opioid analgesics and have a basic understanding of multimodal pain management at this point, mostly from the introduction of ERAS protocols in our postoperative patients and things like that. But there's actually a Cochrane review of the relative effectiveness of a single dose of a variety of postoperative pain options. These include both opioid and non-opioid medications. It's actually a whole long list of options. It includes quite a few of the medications we use, but unfortunately doesn't include quite a few others. Toradol is not on there, tramadol is not on there, and the only opioid that they are looking at is oxycodone, either on its own or in combination formulations, whereas I think most of us more commonly use hydrocodone and Norco. They presented their results as a number needed to treat to get 50% pain reduction lasting 4 to 6 hours. So simply put, a lower number just indicates more pain relief. There are a couple interesting takeaways. The first is that the single dose analgesic with the lowest number needed to treat, the most effective, is actually a COX-2 inhibitor. It's not an opioid. Unfortunately, it's not approved in the United States. It's available around the world and in Europe. Celebrex, which we more commonly used, is not quite as effective. Non-selective COX inhibitors, such as ibuprofen or naproxen, appear more effective than just a single dose of acetaminophen. But interestingly, the combination of ibuprofen and acetaminophen is more effective than Percocet at a whole variety of doses. That 1.5 number for ibuprofen and acetaminophen is a 600 1 gram combination. The 1.6 is for 400 and 650. Versus the Percocets, which the 1.8 is for 10 milligrams of oxycodone, that's 15 morphine milliequivalents, and 650 of acetaminophen versus the 2.7, which is for 325 and 5 of oxycodone. And then there's this really good, actually, opioid stewardship and otolaryngology review from 2018. I'm going to go through that in a second. I just need to touch on one study first because they used it in formulating their recommendations. This is a prospective cohort study from 2009 conducted in the Netherlands among 217 patients that assessed the level of postoperative pain associated with a variety of otolaryngology procedures. What the study authors determined was that oral and pharyngeal procedures were associated with the most pain. Neck surgeries, including thyroidectomy, excision of branchial cleft cyst, selective neck dissections, as well as salivary gland surgeries, parotidectomy, and submax excision, were associated with an intermediate level of pain. And then otologic surgeries, endoscopic and laryngology procedures, as well as sinus procedures, were typically associated with the least pain. So the recommendations on this Kramer paper kind of were based on those groups. For their mild pain category, which again includes endoscopic laryngeal cases, otologic surgery, nasal and sinus surgeries, they recommend against prescribing any post-op opioids at all. Their recommended pain strategy was pre-medication with acetaminophen and a gabapentinoid, and then post-operatively they recommend scheduled Tylenol with as-needed Celebrex or naproxen for breakthrough pain. For the intermediate pain category, which includes neck surgeries such as thyroidectomy, parathyroidectomy, excision of branchial cleft cyst, sentinel node biopsy, and then salivary gland procedures, they recommended pre-medication again with acetaminophen, gabapentin, and Celebrex. This time they added Celebrex to the preoperative regimen. And then post-operatively, they recommended, now we're starting to see kind of more our ERAS meds. They recommended scheduled Tylenol and Celebrex. They recommend considering a scheduled gabapentinoid, and they recommend tramadol as needed for breakthrough pain. For their high pain category, which includes those oral and pharyngeal procedures like tonsillectomy, UPPP, TORS procedures, as well as significant oncologic surgeries like your free flaps, your laryngectomies, these procedures, they recommended that same pre-medication with acetaminophen, gabapentinoid, and Celebrex. Post-operatively, they recommended Tylenol and Celebrex, and they also recommended considering a gabapentinoid again. And for this, they recommended oxycodone as their breakthrough pain medication. They also highlighted a distinct patient-specific category. These are patients with chronic preoperative opioid use, and they recommended continuing prior narcotic use and then adding the appropriate multimodal agents on top, including additional opioids as needed for breakthrough pain. They also recommended that if the postoperative pain is severe or poorly controlled, that you consult the pain service early. Our next general recommendation is that clinicians should limit opioid prescribing to the lowest effective dose and the shortest duration when treating postoperative pain with opioids. Clinicians should instruct patients and caregivers how to communicate if pain is not controlled or medication side effects occur. Clinicians should educate patients to stop opioids when pain is controlled with non-opioid pain medications and stop all pain medications when postoperative pain has sufficiently resolved. And then there's one final recommendation, which I think is good habit for all of us. You should check in with your patients at a post-operative follow-up to confirm that their pain has resolved, that their pain was effectively treated with the pain medication regimen that you prescribed, and that they're no longer taking opioid pain medications. Those clinical practice guidelines will be released early next year, and I recommend that everyone take a look at them when they do come out. I think that they're really interesting, really useful, and should definitely be used to guide your decision-making regarding opioid prescribing and pain management in your post-operative patients. That's it. Thank you. Does anybody have any questions?
I have a question.
Yeah.
Okay, so I say this all the time, but I'm a very direct person, so I don't want to be rude. First of all, this is fantastic. This is obviously super timely and important for all of us to hear these things and to understand the literature. And you obviously have synthesized it and know the literature so much better than I do, and I'm sure than many other people on this Zoom here. I don't know enough about the literature related to gabapentin. My understanding is that it's, can work well in neuropathic pain, but I personally think it's ridiculous that it's used as it's held up on this pedestal. I don't know what the evidence is, but it's held up on this pedestal as in like all otolaryngology patients are going to get it before surgery because it's part of the ERAS head and neck protocol. For pain surgery that I do, which the pain is inflammatory pain and does not seem to be neuropathic pain, that I think giving patients something that could be sedating without providing pain relief is absolutely the worst thing that you can do. And I've talked to multiple anesthesiologists who actually have told me that the evidence supporting gabapentin is, shall we say, very flimsy. And the state-of-the-art review that is probably the best we have in otolaryngology literature, I could say that the senior author on it, couldn't be nicer, a very nice person, he's part of a group at Stanford that has published 20 to 30 systematic reviews in sleep surgery that reflect that they don't understand anything about how to do systematic reviews. Well, they don't understand when you should do a systematic review. And it's actually, Rodrigo has led a study in otolaryngology showing that across all of otolaryngology, it's actually embarrassing that we keep publishing these systematic reviews. So the idea that that they've done a great state-of-the-art review, probably the best we have, but I don't accept their recommendations because I don't think that the evidence is as strong as they might suggest that it would be. So my question for you is, what really is your understanding of the evidence supporting gabapentin? Because I can tell you that my patients have a long duration of significant pain, and there have been some otolaryngologists that have had procedures on even tonsillectomy in adults and tell you that it lasts a lot longer than a week, and it's something that is pretty intense, and it's a battle every time to beat the anesthesiologists to the pre-op area so they don't give them gabapentin every morning.
I think that is, I think that's actually probably pretty accurate. The data around gabapentin is not necessarily as convincing as most would want, and in their recommendations, they say to consider it. And I think that, as we talked about with kind of any of these things, they're breaking things up into this mild pain category, intermediate pain category, and this high pain category. But you kind of have to think about things really holistically. And obviously, the procedures that you're doing, I think that, gabapentin, as you've said, is probably not appropriate. But for those big cancer resections, potentially with perineural invasion, that do have a large element of neuropathic pain, I certainly think it should be considered. In terms of the overall effectiveness of a single dose of gabapentin, I wish it were on that Cochrane review, but unfortunately it's not. My understanding of its effectiveness is that basically in some people it works quite well with certain types of pain, and in others it's not effective at all. And in the people that it may work, the majority of them do have neuropathic pain, but even some people with acute post-operative pain, which is largely inflammatory, do seem to get some benefit from gabapentin, at least, in my limited review, that's my understanding.
I appreciate it.
Eric, when we instituted our ERAS protocol, that was the gabapentin was definitely controversial amongst some of the anesthesiologists, and some of the folks didn't really agree with the ERAS protocol, and others did. Also, the gabapentin that they're getting for ERAS, they're getting loaded on it, so they get it pre-op along with Celebrex. I think they're taking it 3 days pre-op and then post-op, and then they go home with a week's taper of the gabapentin, which is apparently, something that is a real thing, is that they can have, if they just cut the meds immediately without a taper, they're at risk of seizures. So that's also, a reason where you would want to think carefully about prescribing it.
Yeah, I mean, I use high-dose Celebrex from the USC anesthesiologist talking about it does not seem to have in vitro anticoagulant properties, at least. And I've been very happy with it, and I think it makes a lot of sense. So I'm open to new things, but I actually think gabapentin would be contraindicated because it's actually going to sedate you without providing pain relief. And that's why I'm, pretty irritated when they just sort of automatically want to do that. So I send emails, try to do them the night before to the anesthesiologists. They don't even look at their emails sometimes. They got to meet them into the room. It's just a little bit of this game. It's absurd that it's been accepted as gospel.
Yeah, definitely some patients get heavily sedated from it and can't take it.
Hey, Steve, it's Mark Swanson. Just a quick comment. I think the key for non-opiate medications is multimodality. So whether it includes gabapentin or not, I don't think is important, but where it can include an NSAID and Tylenol and other non-opiate medications is where the benefit is. And when we were starting it, I kind of thought it would be a trade-off. We prescribe a little bit less narcotics, with the assumption that they'd be under a little bit more pain, but it would be better long-term because they'd be more active and stuff like that. And it turned out not to be the case. We prescribe less narcotics and their pain scores are better, and they feel better. So not only are we withholding narcotics, but they're actually having better pain as a result. And they don't feel quite so sedated. They don't feel quite so cloudy. So they're a little bit able to participate in the recovery and get out of bed a little bit earlier. They don't have the nausea that they get with tube feeds and that kind of stuff. So there's some secondary benefits as well, besides just, avoiding long-term opiate dependence.
Yeah, I think that's absolutely true, especially in the inpatient population. But I think it's also important to touch on, and these guidelines touch on it, for the majority of these patients that are probably going to be undergoing outpatient procedures, there's a huge factor before the procedure, even in counseling your patient, talking to them about the benefits of multimodality pain therapy, talking with them about opioid reduction techniques, and talking with them about just kind of what to expect pain-wise. That I think some of us, I as a resident certainly gloss over a lot of that a little bit too much. I might talk to the patient in pre-op about it, but when I'm consenting them for surgery, I very rarely include any specifics about post-operative pain management. And I think bringing that conversation on a little bit earlier is actually really effective, and it helps set expectations and can put the patient at ease a little bit earlier. If it's not in the inpatient setting, it's more just an outpatient surgery with your plan and with potentially opioid prescribing.
That lack of discussion is not limited to residents. That's something that most
I assumed, but I didn't want to say.
No, it's, when you spend 30 minutes, talking about their free flap and all that kind of stuff, and they ask how painful is it? Say, well, yeah, it hurts, but you're going to get, pain meds afterwards. And that's about the extent of the discussion. Yeah. Having a plan with your patients is great, but there's so many other things that you have to talk about and it's hard to do.
Any other questions? I'd love to save the PGY2s from having to present.
Hey, Steve, it's Ito. I'm just wondering, I know here at CAC we prescribe a lot of tramadol after our surgeries for patients going home. Is there like any good data that you found or information about tramadol, just as, because I know it wasn't included in that chart of modalities when you compare a single dose, but just like its actually its effectiveness postoperatively, and then its risk on postoperative opioid dependence.
I haven't seen anything specifically looking at individual opioids and the associated risk of dependence long-term afterwards, so I can't comment on that. I think that most people regard tramadol, and what I've seen, as kind of a quote-unquote weaker opioid. That weakness is really just its morphine bill equivalent conversion factor. At its doses, you're getting kind of a similar amount of opioid pain relief as you would get with something like hydrocodone. So it's similarly effective to other formulations. But I haven't seen anything tying it really to long-term use or anything like that.
One comment on one of your last slides about the amount of meds that should be prescribed post-op. I mean, one thing I find that I think you guys as residents are all pretty good about not prescribing a whole lot of the meds for patients, but some of these guys, they go through, their prescription that they're sent home with in like 2 days, and then they're calling the office pretty quickly. And it's sometimes a challenge to manage some of the pain post-operatively, and sometimes hard to predict who's going to need it. I think some of those, the numbers you're looking at for, in some of those papers you quoted, don't totally apply to the big head and neck procedures. And pain control can be an issue with these guys afterwards. And unfortunately, getting pain management on board is not always easy. Some pain specialists are willing to help, and other people do not want to take ownership for the pain management of those patients.
Yeah, and I think your head and neck cancer patients are, they have quite a bit more pain and much more challenging to control pain. So really for this, I kind of tried to stay away mostly from the cancer patients and look more at non-oncologic procedures, which was kind of what I was more focused on. And I touched on briefly some actual like pill recommendations, but those clinical practice guidelines are actually, I didn't want to publish them, or I didn't want to share them because I didn't feel they were mine to share. But they do include basically pill number recommendations for about 20 different common procedures in otolaryngology, which I think would be, not hard and fast by any stretch, but certainly a good reference for when you're thinking about what you're going to send your patients home with.
It also can bail you out a little bit. Tell the patient, if sorry, that's all you get.
Yeah, echoing what some of the other folks have said, I think advanced head and neck cancer is sort of a separate category a little bit. For other more minor surgeries, I think that preoperative counseling is really important. And I think that sharing some of the data can help a lot. I tell patients getting parathyroid surgery that, they're going to have a really sore throat, but that's from their breathing tube, and that goes away in a couple of days. I share some of the data, like, on average, patients take about one opioid pain tablet per thyroid surgery, based on like a project we did at Loma Linda. So I think just giving them that information helps them, understand it a little bit better.